Lung and Bronchus Cancer by Julie Phillip. Lung and bronchus cancer is the most avoidable cancer and is the leading cause of death among all cancers. The World Cancer Report published by the World Health Organization in 2014, a total of 1.82 million people developed lung cancer in 2012, with the worst incident rate in China accounting for 36% of new cases per year. While this presentation will focus on the United States incident rate and mortality, this provides a good comparison for worldwide view of the lung and bronchus cancer is consistent throughout the world. At a glance, the U.S. does have decline of incidence. However, there's still estimated over 200,000 new cases of lung bronchus cancer and an estimated of 154 deaths in 2018 to lung and bronchus cancer. This represents 13.9% of all the cancers. The 5-year survival rate is at 18.6%. This is a small population of almost a small city. Comparing incidence rates to death rates shows greater death rate in the dark brown areas of all the cancer rates. There is an important note that you might not be able to see in the first picture, but Delaware is among one of these to be the highest rates of cancer rates. As you can see, the graph fluctuates to smoking trends. In 1992 was the highest incident of death rate, then stricter smoking laws in public buildings, increase in cigarette costs, decreased rate of smoking has shown a steady decline. If we look at the new cases and deaths for race and sex, lung cancer is more common in men than women, particularly African American men. Smoking is widely recognized as a leading cause of lung cancer. The number of new cases of lung and bronchus cancer is about 54 per 100,000 in men and women per year, based on evidence from 2011 to 2015. Death rates for lung cancer are higher among the middle-aged and older population. Lung and bronchus cancer is the first leading cause of cancer in the United States. The number of deaths, 43 per 100,000 men and women per year based on 2011 to 2015 deaths. The number one risk factor is cigarette smoking. It's leading the cause and causing the greatest exposure. Other types is regular tobacco, secondhand smoke, exposure to hazardous substances such as asbestos, radon, could also contribute to lung cancer. There are other carcinogenics, air pollution, uranium, inhaled chemicals, arsenic in drinking water, and radiation, and family history of lung cancer. There are two main types of lung bronchus cancer. About 80 to 85% of lung cancers are non-small cell lung cancer. About 10 to 15% are small cell lung cancer. Of particular note, these types of lung cancers grow differently and are treated differently. Lung cancer locations can occur in the bronchi, central lung, mostly found with smokers, or peripheral lung field within the fine bronchi and air sacs. These can contribute to both smokers and non-smokers. If we look at non-small cell lung cancer, about 80% of the lung cancers, we see there's 4 subtypes: adenocarcinoma, squamous cell, large cell carcinoma, and other type. 40% is adenocarcinoma, occurs mainly in current or former smokers. It's common in non-smokers and can be common in women more than men. And these can occur in the younger generation than other types of lung cancer. Location is usually found in the outer part of the lung. There's a better survival rate as it's a slow-growing cancer than other lung cancers and could possibly be found before it spreads. Another subtype of non-small lung cancer is squamous cell carcinoma, 25 to 30% of all lung cancers. These are flat cells that line the inside of the airways in the lungs, found often in the central part of the lung near the main bronchus, often linked to a history of smoking. Large cell carcinoma is a subtype of non-small cell carcinoma. It's 10 to 15%. It grows quickly and is a subtype of this cancer, is also a neuroendocrine carcinoma that is similar to small cell carcinoma. Fast growing, and it is similar to the small cell carcinoma. The other types of carcinoid tumors is about 5%. Adenosquamous carcinoma, acromoitoid carcinoma, these are less common. Non-small cell lung cancer grows slower, so it can be caught earlier and is used screening tools and then to stage the cancer. The staging is called tumor nodes malignancy, TNM, and it depends on how large the tumor is. Has it grown into other structures or organs? Has it gotten to the lymph nodes? And there's numbers for each one of these, and then metastasized. For instance, depending on the staging will guide the treatment. A stage 1 of non-small cell lung cancer has about a 92% 5-year overall survival. However, whereas stage 4 has less survival rate of less than 1%. Small cell lung cancer is 10 to 15% of the lung cancers. Because it grows fast and it metastasizes quickly to the lymph nodes, then to other organs, it is hard to stage. Small cell lung cancer can be limited, meaning one side of the lung only has tumors, or it can be extensive, including both lungs. It can also secrete hormones that can cause paraneoplastic syndrome, causing fluctuations within the body such as hypertension, water retention, elevated blood sugars, edema, and even antibodies. Since a small cell is usually not found until it has symptoms, treatment usually involves chemotherapy and radiation. So how do we determine to screen for lung cancer? If they've already developed symptoms, it's imperative to use screening and stage the cancer if it's present. The symptoms include a cough, a sputum without a fever, weight loss. Then if they smoke, the smoking history, if they're over 55 and they're a current smoker or have quit in the past 15 years, or a 30-pack year smoking history, this should indicate a high risk of lung cancer and should be screened. If suspect lung cancer, choosing the right screening tool is the best method. X-rays are not effective in diagnosing or finding lung tumors, as there are blind spots creating false negative or even false positive results, and creating exposure to radiation should be considered. The low-dose spiral CT scans have proven less death rate by 16%. The National Lung Screening Trial, large randomized trial that had over 50,000 participants, where 26,000 were low-dose CT scans and the other 26 were assigned to radiography, chest x-rays. After removing the variables, they found that the CT scan low dose mortality was reduced by 16% than the chest x-ray. All-cause mortality was decreased by 6.7%. Overall, lung cancer was diagnosed in 1.1% to 4%. Of the screen participants, most of these were early-staged lung disease. Based on the solid evidence, randomized controlled trials, approximately 96% of all positive low-dose CT scan screening exams did not result in lung cancer diagnosis, leaving false positive exams that could result in unnecessary invasive diagnostic procedures. A total of 0.06% of the false positive screening results led to major complications after the invasive procedure. Over 3 screening rounds, 1.8% of the participants who did not have lung cancer had an invasive procedure following a positive screening results. So let's look at screening by chest x-ray or sputum cytology. Based on solid evidence here, screening with a chest x-ray or sputum cytology does not reduce the mortality from cancer in the general population or even smokers. At least 95% of all positive chest x-ray screening exams do not result in lung cancer diagnosis. Again, we have false positive exams resulting in unnecessary invasive diagnostic procedures, overdiagnoses. Diagnostic procedures, harms, and treatment occur most frequently among the long-term or heavy smokers because of the smoking-associated comorbidities that increase propagation. This graphic here is investigators developed an individual risk model to assess who might benefit from screening. The model used additional factors not previously used in the National Lung Screening Trial inclusion criteria, resulting in the number of false positive screens decreased, the mortality decreased from the screening. These studies illustrate possible improvements for determining the population of patients who may benefit the most from screening, basically pointing out there should be individual risk scores to determine if need to have screening. Take note to look at Panel A for the lung cancer mortality ratio for low-dose CT group versus chest x-rays. Then Panel B shows the number of lung cancer deaths prevented by low-dose CT among risk quintiles, the exact boundaries for the risk of a 5-year lung cancer. The bar notes 95% confidence interval. The horizontal gray lines indicate the overall efficiency of low-dose CT screening. The gray symbols indicate the efficiency outcomes and risk quintiles as defined by 4 published prediction models of the lung cancer incidence. So what are the risks for lung cancer screening? Chest x-ray and low-dose spiral CT scans expose the chest to radiation. We naturally have about 3 MSVs per year from natural radiation and cosmic radiation from outer space. If you look at this chart, this is showing us that a chest x-ray is 0.1 is equal to 10 days, and 1.5 of a lung cancer screening CT is equal to 6 months, and then a regular CT is equal to 2 years. So the key points are determine if they have risk to have screens with these types of screening tools. The risk of lung cancer screening test cannot improve health or help someone live longer. It can create false positive test results or false negative test results. What is in the future? Study is needed on e-cigarettes, vapor, threatening is to increase lung cancer. There is not enough studies out yet for this. It's still fairly new and has long-term effects. The American Cancer Society is closely watching. There is also increased research to improve screening and treatment modalities. One of them specifically is using blood, protein biomarkers, and autoantibodies. These screening studies have been conducted in the United States and have revealed staging lung cancer at stage 1. These can be used for asymptomatic people, and it has a higher specificity than image testing. Overall, as a provider, strong evidence shows that low-dose spiral CT screening can reduce lung cancer and all-cause mortality. The harms associated with the screening must be balanced with the benefits. With new technologies and new ways to find screening for lung cancer and treatment, I hope that we will see that in our lifetime. This is a cartoon for the new year. Hope you enjoyed this presentation. My references will be attached in a Word document. Thank you.